right, welcome everybody. My name is Aviva Ariel Donjas. I'm the health psychology intern at Jesse Brown, the VA in Chicago, and the student council chair for Division 38 Society for Health Psychology. So welcome everyone to our final health psychology seminar series of 2018. Sadly, today is our last speaker. And hopefully by the end of the calendar year, I'll have all of these presentations uploaded to the Division 38 website. So I'll send out an email to everyone letting them know when that's happened. For those of you who are streaming online, if you will type into the chat box where you're typing in from, so either your program or your city or the place that you work, just so we get a sense of who is tuning in. Today, I am honored to introduce Dr. Priyanka Parikh, who's a postdoctoral fellow at the Jesse Brown VA Medical. Dr. Parikh obtained her PsyD at the Florida Institute of Technology, and she completed her internship at the Alaska VA Healthcare System in Anchorage. At Jesse Brown, she's the PTSD Pain Substance Use Disorder Psychology Postdoc Fellow. So today we're thrilled to welcome Dr. Parikh to talk about pain and PTSD.
Thank you for the introduction. Welcome, everybody. Today, we are going to talk about PTSD and chronic pain. So we'll cover about what is chronic pain, go over PTSD, we'll go over the overlapping factors of PTSD and pain, clinical implications, and the best practice recommendations from the DoD and VA. So what is pain? It is, of course, an unpleasant sensory and emotional experience, which is associated with an actual or potential tissue damage, or described in terms of such damage. So we'll go into more also different types of pain, but when we talk about types of pain, they're also referred as acute pain versus chronic pain. So acute pain, it lasts less than 3 months. It is considered as a symptom because especially has an identifiable cause, and it usually diminishes after with healing period or the treatment. Chronic pain lasts more than 3 months to 6 months. It is a condition. It may have a known or unknown cause, and it usually persists beyond the expected healing time and treatment. The other types of pain are nociceptive pain and neuropathic pain. So nociceptive pain is normal pain. It results from a trauma or an injury to a body tissue. It's experienced as throbbing, aching, dull or sharp, and usually fades after an injury heals or pain stimulus is taken away. Neuropathic pain results from damage or dysfunction of nerves of sensory transmission system. It's experienced as throbbing, burning, tingling, or electrical. It does not always go away when patient heals or stimulus is taken away. So nociceptive pain could also result from surgery or an injury, such as sprain, scrape, burn, or fracture. The neuropathic pain is very frustrating for many patients because it often does not provide adequate pain relief. And the most common causes of neuropathic pain are diabetes, painful shingles, sciatica, Agent Orange exposure, vitamin B12 deficiency, thyroid disease, alcohol use, so post-stroke syndrome. So there are many different reasons, and you can see why that could be frustrating for patients and providers as well. Neuroplastic pain is it's a new term. So pain where somebody experiences pain, but where there is no tissue damage or there's no evidence of such damage, and it adapts or changes in response to function. And sensitization means is like maybe it's a lot of times with people who have neuroplastic pain could experience the pain maybe at different parts of the body. You may have also heard of the term fibromyalgia. It could be one of the ways could explain neuroplastic pain. What I mean by amplified when in distress is just like a guitar string. Like the tighter you tie to the guitar string, the more amplified it is going to be just with the pain. The more you are distressed in general, the pain is going to be amplified as well. So chronic pain, Turk defines pain as multidimensional, complex, subjective perceptual phenomena. So as pain, the chronicity of pain increases, emotional distress, functional limitations, there's also increase in utilization of healthcare system tend to occur. So the cycle of chronic pain is self-perpetuating and self-reinforcing. And so what I mean by that, so as painful sensations lead to a tendency to guard or avoid activity or therapy, which in turn then leads to atrophied muscles, decreased range of motion, flexibility, and ultimately serves the maintenance of pain cycle. So when it comes to chronic pain, as you can notice, it affects chronic pain affects more people, more Americans than diabetes, heart disease, or cancer combined. So basically, the chart below depicts the number of chronic pain sufferers compared to the major health conditions. So it's 100 million Americans basically are affected by chronic pain. And that's a lot of people. 4 common conditions for chronic pain. According to the National Institute of Health Statistics survey, they did a survey, and what they found that 27% of people complained about low back pain, and which resulted from muscle strain, or herniated disc or degenerative disc disorders, or spinal stenosis or arthritis. 15% reported severe headache or migraine pain. Neck pain was 15%, and of course facial ache or pain was 4%. And back pain, as you see, is leading cause of disability of Americans, especially under 45 years of age. And so more than 26 million Americans between the ages of 20 to 64 experience frequent back pain. So I'm sure every one of us in this room have, or online, have experienced back pain in their life, and might even experience more back pain in the future. So adults with low back pain are often in worse physical and mental health than those who do not have low back pain. 26% of adults with low back pain reported limited activity due to chronic condition, as compared to 10% of adults who did not have low back pain. So also adults reporting low back pain were 3 times as likely to be in a fair or poor health, and more than 4 times as likely to experience serious psychological distress as people without the low back pain. So these are some of the other common chronic pain conditions, middle, upper back pain, neck pain, arthritis, pelvic pain, of course, which is more common in women due to medical conditions such as endometriosis and pelvic floor tension. Also, you have fibromyalgia, phantom limb pain, headaches, and neuropathic pain, which you already covered. So when it comes to pain scale, especially when we're working in pain clinic, this is something we cover, so that way there is more of a proper communication between providers and the patients. So it's based on 0 to 10 scale. So as you can see on the chart, is 0 being no pain, 10 being as bad as it could be, and especially 10 could also result in going to an ER, for example, because it's excruciating pain. So this kind of gives us more of an idea and more of an understanding for our patients, okay, how bad is it, and then they can communicate adequately with the providers. Or you can also use this pain scale. So chronic pain syndrome. So chronic pain impacts individuals in various domains of functioning. It's not fun. So as the fear of pain begins to dictate physical activities, physical functioning declines with an increase in inactivity behaviors, which turns, as I mentioned earlier, atrophies muscles, results in decreased range of motion or flexibility, which then may affect emotional functioning, resulting in depression, irritability, or anxiety. And then the ability to cope with pain may be compromised, resulting in the development of maladaptive or avoidant strategies to manage its effects. Other areas such as relationships, occupational functioning, social functioning may suffer greatly due to the avoidance and withdrawal, which then likely increases patients' distress and disability, which will then increase their pain experience, and basically the cycle just keeps on continuing. So also another way we refer to this is the chronic pain cycle. So there are some key findings from the chronic pain survey. So they surveyed 303 patients who had chronic pain. 51% felt that they had no control over their pain. 60% talked about that they experienced breakthrough pain one or more times daily. What I mean by breakthrough pain is basically they are getting treatments for the pain, but it still seems to break through those treatments, which also severely affects their quality of life and overall well-being, because also when breakthrough pain happens quite a bit with patients who have cancer. 59% reported an impact on their overall enjoyment of life. 77% reported feeling depressed, which is a really high number. As you know, looking at the chronic pain syndrome, the chronic pain cycle, talked about how it not only impacts their physical activity, but also our mental health. And 77% is really high. And 70% reported difficulty concentrating. 74% reported energy level was impacted. 86% reported inability to sleep. And if you look at it more this comprehensively, it affects your sleep. So that means that your body is not repairing itself. So then if it's not repairing itself, it's going to increase the pain experience. If it's not repairing itself physically and emotionally, it's also going to impact the mental health even more. So that's one of the reasons why it's so important to look at the pain management and mental health management overall. So we're going to go into a little bit of the theory. So there are several theories that are out, and we're going to talk about three. So I always mess this word up, specificity theory is one of the first modern theories of pain. It holds that specific pain receptors transmit signals to a pain center in the brain that produces the perception of pain. So this theory is correct in that the separate fibers for pain signals do carry the pain signals to the brain eventually. However, the theory does not account for the wide range of psychological factors that affect our perception for pain. So, for example, like active duty military may report little or no pain in relation to a serious wound in wartime that would otherwise be excruciating. Right? I'm sure you've also have all experience. You may have cut your finger by paper cutting. You may not even notice and might not even feel it unless you see it and then it's like, oh, it hurts. So specificity to the theory. It's one of my words that I can never get right. Basically, pain equals to tissue damage. So there is an actual tissue damage. That's why somebody is experiencing the pain. The other one is called pattern theory. It holds that the pain signals are sent to brain only when stimuli sum together to produce a specific combination or pattern. So the theory does not pose specialized receptors for pain, nor does it see that the brain as having control over the perception of pain. Rather, the brain is merely viewed as a message center, as more like a message recipient. So despite its limitation, actually the pattern theory did set the stage for the next theory we're going to talk about. It's called the gate theory, that has proved the most influential and best accepted pain theory so far. Gate control theory is basically like a gate-like neural mechanism. It can account for both top-down brain influences on pain perception, as well as the effects of other tactile stimuli, example, rubbing a banged knee, which also appears to reduce pain. It is proposed that there is a gate or control system in the dorsal horn of the spinal cord through which all the information regarding pain must pass before reaching the brain. So basically there is in the dorsal horn that controls whether the gate is open or closed. Okay, and what I mean by open and closed, so then when the open gate is open, the signal goes through, the pain is perceived, and when the gate is closed, there is no pain signal is sent to the brain. So there are some factors that affect that open the gate of the pain. So physical deconditioning, basically being inactive, muscle tension, atrophied muscles, directing attention to the pain, so focusing on the pain, thinking about the worst of your pain, like in amplifying that pain, emotions such as anxiety, depression, all negative emotions, lack of pleasurable activities, lack of involvement in social activities, isolation, withdrawal, all of that basically opens the gate up, which means the pain experience, the perception of pain is going to be more versus when the gate is closed. And some of the factors that contribute to the gate being closed are increased physical activity, which then is going to decrease muscle tension. It's going to decrease, medications also. Cognitive, focusing attention on activities that are more pleasurable, that keeps you more engaged, which also actually that challenges your negative thoughts, and seeing pain as more of a predictable and controllable rather than something that's uncontrollable. Having more positive emotions and being at more at peace and more of an acceptance. Activities like doing rewarding, fun activities, discovering new hobbies, having more of a balance between too much or too little, and of course, spending more time with your friends, with your families, and that brings you more joy. All of these factors is gonna keep that gate closed, is what the theory says, which means then all these those nerve cells that are firing will not pass through that gate, so your pain experience is not going to be as much. The physical and emotional pain have similar neural signatures. So when people feel emotional pain, the same areas of brain get activated as when people feel physical pain, which is the anterior insula and the anterior cingulate cortex. In one study, these regions were activated when people experienced an experimental social rejection from peers. In other, more real-life study, the same regions were activated when people who had recently broken up with romantic partners viewed photographs of their partners. And they did a little interesting study I came across where it talks about, okay, if the physical and emotional pain goes through the same circuit, neural circuit basically, can we treat emotional pain the same way we treat physical pain? And they did the study to understand more about that and not to push the Tylenol, for example. So basically that's what they used in the study, is they had randomly assigned groups to take Tylenol versus placebo for 3 weeks. And the people who took Tylenol reported fewer hurt feelings during that period. When their brains were scanned at the end of the treatment, those who were in the Tylenol group had less activation in the anterior insula and the anterior cingulate cortex. So it was not, once again, to push Tylenol on people, but it was more to learn about the single neural system to detect pain. Also, another study investigated whether an attachment figure acts as a safety signal by exploring whether viewing the attachment figure during a threatening experience increased in activity in the neural region associated with safety signaling. So basically what they found was when they looked at, one second, it's called ventral medial prefrontal cortex. So what they found was when people were presented with traumatic stimuli and also looked at the attachment figures that increased the feeling safe, they noticed more activity in the ventral medial prefrontal cortex. And also notice decreased activity in the anterior cingulate cortex and anterior insula. So PTSD and pain. So we talked about the anterior insula just a little bit ago. So as you can see, there is an increased activation in pain. So also there's an increased activation in the anterior insula, even with those who have anxiety and PTSD. And what they notice also is that anterior insula is not only noticed in pain and anxiety processing, but also is noticed in integration of current interoceptive, cognitive, emotional experience, as well as in mounting affective and autonomic responses. And evidence indicates that the anterior insula is basically a neural substrate for emotional salience, emotional awareness, and subjective feeling state. So therefore, basically, increased activation within the anterior insula in PTSD during an experimental pain processing suggests increased subjective emotional reactivity to stimuli. So research suggests that the exposure to aversive experiences, such as experimental pain, makes individuals with PTSD avoid or dissociate from aversive experiences that are more painful, which can then lead to reduced subjective pain experiences and reduced brain response. So what they found was that both the degree of the reduction in the subjective pain experience and the right anterior insula activation related to the degree of avoidance symptoms in women, especially with PTSD. So such mechanisms such as the avoidance, dissociation, and even derealization may compensate for greater emotional distress associated with pain experience. Also, what they found was when they did the study, they noticed that those who had PTSD versus those who did not have PTSD, when they were presented with traumatic reminders, their initial brain response to the experimental pain they noticed more increase in the anterior insula, even in the initial brain response versus those who did not have PTSD. So let's talk a little bit more about the comparing models of pain management. More so now, we are more focused in providing a biopsychosocial type of care because biomedical care looked at body and mind separate and looked at pain as symptom, as we already know that acute pain is more considered as a symptom, and after that, it's no longer a symptom. It's a more complex problem. Biomedical's goal was to identify the cause of it, cure it, provide short-term relief, and that's it. So it is more appropriate for acute pain. Now, biopsychosocial is more appropriate for chronic pain and something that we do see more often. So it is more of a holistic. You are treating the person and not just a symptom. You are looking at many different aspects and factors that contribute to the pain. So basically, biomedical was more of outdated approach to pain, and now we focus more on the biopsychosocial because it emphasized the importance of taking into account the dynamic and complex interaction among physiological, psychological, and social factors that perpetuate and may worsen the pain. So you look at it in each individual as separate. Each individual experience pain uniquely, and based on those interactions, you're able to tailor what's going to be a best treatment plan that's going to address their specific needs. So biopsychosocial is basically, tailoring the treatment plan to each individual person, so that way each of their concern is addressed and it's not just one size fits all. Psychosocial treatment for chronic pain. There's the cognitive behavioral therapy for chronic pain, which focuses on doing things differently to change the experience with pain. Because, as you know, cognitive behavioral therapy proposes that the thought affect how one feels and behaves. So this relationship is dynamic and multi-directional. And cognitions or thoughts develop in part as a result of social learning and may be adaptive or maladaptive in scope. So it really focuses on how are they doing those things and how we can they can do things differently to change the experience with pain. The other one is acceptance and commitment for chronic pain, which focuses on changing relationship with pain that may always be there and working towards more acceptance. So some of the general goals for these treatments is to provide information, provide knowledge, so then it increases their awareness about their pain and the contributing factors. It gives them more of knowledge about an awareness about how their pain affects their social life and how that turns into isolation and inactivity, and that cycle just keeps on going. And so having that awareness makes them more ready to identify what actions affect what, basically. It also helps them set realistic expectations, because a lot of times when people are in pain, they want the pain to go away, and that's not reality. Pain serves a really important factor. It's for survival. If we can't tell if we're in pain, we would continue to hurt ourselves and eventually not be alive. So it serves we want to set a realistic expectation. So it's more about managing the pain. We can't make the pain go away. Also, building an understanding of the mind-body connection, promoting self-management. And by that, we want to get them more engaged in their care, where they are also taking more responsibility to take care of themselves and doing activity that requires more of an active stance. Building self-efficacy goals also to decrease emotional distress, as we already noticed how that gets impacted. And also finding the right balance of activity. So a lot of times people are upset about the things that they cannot do because of being in pain. So we want to set realistic expectations and goals and finding healthier ways of doing activities they still can, but in a way that it's not going to increase their pain, but still they are being active. So the overall goal is to improve their functioning and the quality of life and reduce the reliance on medication or invasive treatment, and of course reduce pain. So this is more of the comprehensive pain management model. So as we talked about, there's chronic pain, there's muscle, that could be tense muscle spasm, fatigue, inactivity, muscle atrophy, depressed mood, poor health, and pain progression and sick role. So comprehensive pain management model, it's not like just one treatment will fit all. There are times that people come into the pain clinic, and let's say, for example, they have sleep apnea. If they have sleep apnea and they're not using their CPAP, it's also going to increase their pain experience. So we want to really look at their life as a whole and see what is contributing to the pain experience and what can we do to help them manage different aspects in their life that will then overall reduce pain. For that, we want them to be involved in going to wellness center, going to like pool therapy. These are some of the services that are offered at the VA. So MOVE is a group where they talk about making dietary changes, which then will also, of course, help with pain. And get them engaged in art therapy. Once again, get them engaged in more pleasurable activities, which is going to improve their mood. There is biofeedback. There's, of course, the pain groups, which are cognitive behavioral therapy and acceptance commitment therapy, smoking cessation, and just other pain management could be, manipulation like chiropractic care, acupuncture, meditation, and so forth. So what is PTSD? So PTSD means that it occurred is post-after. So after somebody experienced a traumatic situation. And I'll go into a little bit more. So it has somebody who experienced a traumatic situation. It can come up, even all the stress from it could come up even 10 years or decades later. It has to last at least 1 month. So traumatic means like exposure to death, serious injury, or sexual violence. It could be primary or secondary exposure. It could be related to combat, childhood abuse, sexual or physical, sexual assault, physical assault, serious accident, or natural disaster. Stress means natural reactions. So basically, stress is like a natural reaction to abnormal situations, which is often the fight, flight, or freeze response. So either you fight in this stressful situation, you run away, or you freeze because of the traumatic situation is so overwhelming and likely repetitive. Disorder, D of course stands for disorder, but I also like to look at it as more of a disruption because it's a disruption in the natural recovery process. So for those who have PTSD, they they're going to experience these more four symptoms. The hyperarousal. Hyperarousal looks like being easily startled. Negative thoughts, negative thoughts about themselves, where they may not of course, negative thoughts of themselves isn't like they might look at themselves negatively and have negative self-perception. They may also have negative perception about the world and those around them. They may have difficulty experiencing positive emotions. Re-experiencing looks like flashbacks, or intrusive thoughts where basically thoughts pop up without even thinking about the event, or it could be cued with a trigger that reminds them of the trauma. And avoidance is basically, as it sounds, avoidance, avoiding thinking about the event, avoiding going to places that reminds them of the event, avoiding people that remind them of the event. And as you can notice, that just what we notice with the avoidance with pain, same thing with PTSD, what happens is that by avoiding, it also leads to withdrawal and inactivity and isolation. So just a little bit of a refresher for the DSM-5 PTSD criteria is, as I mentioned, exposure to traumatic stressors include death, threatened death, actual or threatened serious injury, or an actual or threatened sexual violence, which includes the intrusion symptoms, which I know intrusive thoughts, nightmares, flashbacks, avoidance. Also, the one thing is about avoidance, not just about the external avoidance, is the internal avoidance. The internal is basically thinking about it, and the external that the places that could remind them. So, and also the negative alteration in mood and alteration of arousal, reactivity, in which also means the irritability, aggression, self-destructive behavior, hypervigilance, or the startle response, which could also result into problems concentrating and sleep disturbance. Symptoms last more than 1 month, significant functional impairment not due to medication or illness or substance. So I'll talk a little bit about amygdala and PTSD and pain. So the amygdala is a limbic structure involved in emotional processing and is critical for the acquisition of fear response. So the functional role of amygdala in mediating both stress response and emotional learning implicates its role in its pathophysiology of PTSD. So functional imaging studies have revealed hyperresponsiveness in PTSD during the presentation of stressful scripts or cues or trauma reminders. So PTSD, the patients who had PTSD further showed increased amygdala responses to general emotional stimuli that are not trauma associated, such as emotional faces. The amygdala also seems to be sensitized to the presentation of threatening cues in patients with PTSD, and increased activation of amygdala has been reported in PTSD patients during fear acquisition and conditioning experiment. So as you can notice, it has a hyper-responsiveness in PTSD, and it also serves as an important brain center for the emotional affective dimension of pain and for pain modulation. Amygdala also communicates with other brain areas, and it coordinates a specific defense response. The PTSD and pain comorbidity, 50 to 75% of those presenting with PTSD have a chronic pain condition. Among those presenting with chronic pain, among those who were presenting with chronic pain condition, reported PTSD were 20 to 37%. 45% of firefighters with PTSD reported more musculoskeletal pain than those without PTSD. 50% of veterans report experiencing chronic pain. 80% of combat veterans with PTSD experiences chronic pain. Studies of PTSD patients have found that 45 to 80% report presence of chronic pain condition, and between 34 to 50% of patients have PTSD or significant PTSD symptomology, veteran and non-veteran. So, regards to PTSD and pain comorbidity, there was a survey. They surveyed 15,000 veterans, and they found parallel rates for following things. Of those, 54% reported headaches, 45% reported back pain, joint pain, back pain was 44%, muscle pain was 33%, and 23% was abdominal pain. So the rates of PTSD when pain is secondary to a motor vehicle accident was 30 to 50%, and burn patients have high rates of PTSD, it was 45%. PTSD and pain. So patients with chronic pain and PTSD experience more intense pain. And because of that, there is also greater affective distress, which means that there's also greater life interference and more disability. So if we kind of look at that cycle again, we were talking about that pain syndrome, you know, how that pain meant inactivity and negative emotions and avoidance and withdrawal. So same thing with the PTSD. When the people who have PTSD, they are likely to avoid, and they also experience negative emotions. You can just think about how it can intensify the interference it has in life, and further results in isolation, withdrawal, and disability. So there was a relationship found between increased re-experiencing symptoms, which is those thinking, the intrusive thoughts, nightmares, flashbacks. So there was a relationship between those who had those symptoms and increased pain level and pain-related disability. 80% of Vietnam veterans with PTSD reported a chronic pain condition. More PTSD intrusive symptoms also associated with increase in pain level disability, even in that study. PTSD has been identified as a risk factor in the transition from acute to chronic pain. So those who have PTSD basically are more likely to develop chronic pain. And patients in both conditions are less likely to engage in treatment for either condition. So that perpetuates the chronic cycle. So those who in the military often have complex injury profiles and high physical and psychological comorbidity. So most common physical injuries within the military are traumatic brain injury and post-concussive syndromes, fractures, amputations, burns, spinal cord injury, and eye injury. Higher injury to fatality ratio than in any prior war. So the OEF, OIF, OND, that's Operation Iraqi Freedom, Operation New Dawn, Operation Enduring Freedom. So in recent large-scale study, 13% of the veterans seen in the VA facilities were diagnosed with PTSD. PERD estimates also budgetary costs of caring for veterans over the course of their lives are $350 and $700 billion. And one of the reasons, and there has also been higher injury to fatality rate than in prior war, is because advances in medical technologies that results in more veterans who are then in chronic pain. So impact of PTSD. And impact of PTSD, of course, impacts the pain in many different ways. It could result in fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, tension headaches. So for those who have PTSD and exposed to trauma are 2.7 times more likely to be diagnosed with one of the following functional somatic syndrome. Some of the other impact of PTSD are basically the ones that we discussed earlier, the lack of social engagement, avoidance, sleep, and mental health, and so forth. So we'll talk about some 3 different models. First one is going to be fear avoidance models. It's going to kind of go over more into detail about how PTSD and pain overlaps. So basically, the chronic pain and PTSD share the clinical features of fear and avoidance, which we've been talking about, which may influence the development of each condition over time and may serve to maintain them and may interact in the ways that they impact the outcome of either condition. So basically, fundamentally, feared stimuli, both pain and trauma related, are chronically avoided. So if somebody gets hurt by exercising, they're going to be like, you know what, I am not going to exercise again because if I do, I'm going to be in pain again. For those who have PTSD, if they, let's say, went to a place at Walmart and they felt extremely overwhelmed because it reminded them of a traumatic experience and they left, they had this anxiety or panic attack, they left, they're like, you know what, when I went there, I became really overwhelmed, I had a panic attack, so I'm no longer going to go to Walmart. So that's more of that fear, and then it results into avoiding activities. So that's common in both PTSD and pain. So because of that, it basically leads to chronically avoiding, leading to physical, emotional, and cognitive repercussions that impede recovery. So by avoiding that, they are not recovering. They continue to perpetuate the chronic pain cycle. In short, the fear-based avoidance appears to be salient common denominator for the development and the maintenance of chronic pain and PTSD. So individuals with PTSD are driven by fear of re-experiencing overwhelming thoughts or feelings of past traumatic events, and so they avoid reminders associated with traumatic events at all costs. So, for example, a lot of times I hear veterans talk about how fireworks are a big trigger for them, so they will avoid activities around that. That could be New Year, it could be 4th of July, then even just being around in crowded places in general. So that turns into even a bigger picture, avoiding family gatherings, avoiding going grocery shopping, avoiding going to medical doctors, medical appointments, because VA itself is a crowded place. So it's preventing recovery. So this fear avoidance contributes to chronic nature of illness through the prevention, of processing the traumatic event. So without processing the traumatic event, the individuals with PTSD, they're continue and more likely to isolate, so to avoid the traumatic reminders. So there was the same example, with the exercise. So my person might stop exercising, going to gym because they're hurt, but that could then result into even exercising as walking. They might avoid walking for long term because they are in more pain. So if you think about it, let's say for somebody who was exercising, they got hurt, they're avoiding exercising, they're avoiding activity, means they're deconditioning the muscles, which means more pain. So when they are likely to be a little bit more active, they might be in more pain. So they're like, you know what, I'm going to avoid and do it because they're afraid that if more they move, the more they're going to be in pain. So that continues to perpetuate the chronic pain cycle as well. The other one is called a mutual maintenance model. So the mutual maintenance model suggests that shared factors may maintain both chronic pain and PTSD. This model posits that attentional biases or a learned tendency to focus on certain internal or external stimuli results in greater attention to threatening or painful stimuli. So in addition, those with pain and PTSD may demonstrate an increased sensitivity to anxiety symptoms and tend to expect the worst or greater extent than those without either of the conditions, meaning without either of PTSD or pain. Identification of the physiologic sensation of pain as a trauma reminder, and pain is misperceived indication of physical damage. So basically, the cognitive demands of pain and PTSD symptoms limit adaptive coping, and that continues the maladaptive coping. And the anxiety and pain perception is there for both. Anxiety for PTSD is anxiety of being reminded of the trauma and avoiding and doing things, and the anxiety of pain perception is basically anxiety of even moving. could result into the pain perception. So shared vulnerability model is closely related to mutual maintenance model in that it shares its interoceptive focus, but it goes on to propose that the higher the anxiety sensitivity, such as pounding heart or shortness of breath, predispose an individual to respond with greater fear in terms of emotional, phenomenological experience and behavioral reactions to fear than those with lower anxiety sensitivity. So that they have the tendency to respond with fear to physical symptoms of anxiety and is deemed to as a shared vulnerability to the development of chronic pain or PTSD. So what are some of the clinical implications? How, given that there are overlapping factors and of course, they're individual on their own. What's the best way to treat them? Sequential treatment should, what that means is stabilizing one condition and then treat the other. So some evidence suggests that the PTSD treatment improves the somatic symptoms. Basically, the somatic symptoms are those we experience in the chronic pain or pain in other areas. But if the individual is ready for trauma treatment, the chronic pain treatment could serve as a good introduction to treatment, and success could also boost the self-efficacy and increase chances of success in trauma treatment. So the potential risk and disadvantages that is untreated disorder can worsen, and the disagreement as to which disorder should be treated first. And also, it's difficult for patients to also follow through referrals. Parallel treatment is basically treating both disorder, PTSD, and pain simultaneously. So both disorders are addressed right away by specialists in each condition. So it's not doing by one specialist. It's more so patient goes to a therapist to talk about work with PTSD. Other one goes to like maybe pain clinic to manage pain management. Potential risk and disadvantages are that it requires active collaboration among providers. And veterans, in the VA, they are, of course, one hospital. But if you think about it, those who are outside of the VA and use, private hospitals or community hospitals, that's very difficult to have that active communication between two different providers and to have them on the same page to treat the condition. Also, different providers with different philosophy of the treatment are more likely not going to be on the same page, which can then provide a disadvantage for recovery. And also, it diffuses the responsibility among provider with no one taking the full responsibility of the patient. So what's the other one? Integrated treatment, and may overcome some of the limitation of either of these approaches. And basically, integrated treatment is like you're, once again, focusing on patient as a whole and addressing all the things that are going on. And one of the integrated treatments for pain and PTSD is cognitive behavioral therapy for PTSD and pain. It's still in an infant stage of development. So it's presented as group therapy, 12-week sessions, 60 minutes. And as you can see on the right, those are the 12 different sessions that we covered. One of the things that I wanted to touch base on is the rationale for the interoceptive exposure. So basically, the internal sensations can automatically trigger anxiety or panic reaction. So for example, even thinking about, for somebody who has PTSD, even thinking about going to a crowded place could automatically trigger being nervous and feeling nervous. And for somebody who hurt themselves by exercising, even the idea of exercising could react in the same, anxiety or panic reaction. So the goal is to decrease the overreaction in a safe and controlled way. And we talk about how to do that in the therapy. It's more so basically what happens is if you're afraid of something, you continue to avoid it, the anxiety threshold is just going to stay there and it's not going to recover. But if you're afraid of something, there is a fear, and you confront it, the anxiety itself is eventually going to come down and it's going to induce recovery. So we talk about how to do that in a safe and controlled way. So VA DoD clinical practice guidelines, they have 10 recommendations for management of PTSD and chronic pain. And I want to be mindful of time, so because I want to leave some time for question. So basically, I'll go through this very quickly. So it's talking about assessing the pain regularly, taking once again a full biopsychosocial assessment. So we are covering the patient in all different aspects and individualizing the treatment. Also paying attention to their alcohol and substance use and prescription use. And also when we do assessment related to the pain, you want to get more of the detail of the pain score and the pain description, so that way you are able to better form the treatment plan. Also look at how is the pain affecting their functioning? What areas of life are being affected? Because for some it may have a negative impact on their mood. For some it may not. For some it may impact their occupational functioning, but for some it may not. So you kind of really want to get into more of the details, the areas of impairment. Assess pain and the trauma-related avoidance behavior. Also look at more of an interdisciplinary approach and balance the risk and benefits. And of course, beware of drug interaction. Otherwise, provide education about the non-pharmacological modalities of pain control, such as massages, biofeedback, acupuncture, yoga, meditation, aquatic therapy. And also these are really good is because of, for example, the physical therapy, yoga, meditation, aquatic therapy, those are more active engagement, and we want them to be more active in a safer way, so that way it increases their atrophied muscles. So also caution in the use of centrally acting medications, which are opioids, so you always want to be really careful about that and having a conversation with them about it. So pain management takes time. 50% of the patients with moderate pain noted that they took at least 6 months to reach pain of real control. The more the severe pain, the longer it takes. So for 70% of those with the severe months, it took at least 6 months. Successful treatment goal is basically pain reduction and not getting rid of pain. And successful pain reduction is 40 to 60%. And outcome data, of course, suggested that integrated chronic pain management and rehabilitation demonstrate broad-based physical, emotional, and functional gains by patients along with high levels of treatment satisfaction. Questions? Concerns? Everybody knows the Lego pain. Comments? Feedback? Questions?
So at the VA, I know you're treating veterans, but in your experience working with individuals, do you see kind of different sequelae of both traumatic symptoms and pain symptoms depending on the type of trauma the person has experienced?
Absolutely, yes. So for example, I went to training not too long ago for those who experienced military sexual trauma. So what they talked about, those who experience sexual trauma are also more likely to experience, especially in women, pelvic pain. So it can definitely make a difference as to what the trauma was and the pain that they are reporting. Yes.
A request for your slide. No questions from
Okay. All right. All right. Great. Thank you, everybody.
Thank you so much.